I'm Mary Thompson. I'm the moderator today, and I just wanted to welcome everyone to the Department of Family Medicine and Community Health Forum. And today we are very fortunate to have Dr. John Temte with us, yay. And most of you know Dr. Temte. He's been especially busy the last 2.5 years. And John, I just want to share a few highlights regarding your career. John is the Assistant Dean for Public Health and Community Engagement here at UW School of Medicine and Public Health, and yet continues to practice family medicine, working at the Access Community Health Centers, seeing patients, teaching, and engaging in research. Dr. Temte earned his PhD as well in zoology and evolutionary physiology, and his extensive body of research has included investigating the relationships between communities, primary care, and respiratory viruses. Dr. Temte is an expert in vaccines and immunization policy and has served on the U.S. Advisory Committee on Immunization Practices and currently is chair of the Wisconsin Council on Immunization Practices and serves as medical director for Public Health Madison and Dane County. Nationally, John is serving an appointment to the CDC Board of Scientific Counselors. And I could go on with more things that Dr. Temte is involved in, but let's give him time to talk. As you can see, he's going to give us a viral update with a focus on COVID-19 and human monkeypox and influenza. So take it away, Dr. Temte.
Well, thank you so much, Mary. I do appreciate the introduction and hoping that everybody has a wonderful day. To start out, I'm going to just mention a little humility that after a very long time in this pandemic, both my wife and I finally succumbed to COVID-19. And, we succumbed in a foreign country, had to isolate and take care of ourselves there. And the good news is, despite the fact that I'm edging up on that demographic category that puts me at high risk, we sailed through this fairly well. And all I can say is I think this is a testament to the incredible vaccine science out there, and the fact that 2 years ago, what was a dread disease was now more of a nuisance. And we hope it keeps that way. So today I'm going to try and just give current states of COVID-19, monkeypox, and influenza here in Wisconsin and across the globe, and then look a little bit at vaccines and treatment options for the three, along with other observations. So starting with COVID-19 and SARS-CoV-2, this takes me back to a talk I gave back in 2005 and had a graphic here talking about how bad the next flu pandemic is going to be. And they said as bad as 500 Katrinas, nearly 75 million Americans could become infected with this deadly virus. And it turns out that 500 Katrinas is about 960,000 deaths. Well, 2005, they got off by a little bit, by about 30%. We have now had 97 million cases diagnosed in the United States by testing and 1.06 million deaths. So very, very significant. And across the globe, we see a great underestimate and underreporting of cases and deaths. Close to home, we have had about 1.9 million cases in Wisconsin. Again, these are laboratory diagnosed. And that means about 1 out of every 3.2 of us have had a lab confirmed diagnosis. We've had 15,000 deaths, so about 1 out of every 385 of us have succumbed to COVID-19. But I'd like to take the data and kind of reimagine it. So this is looking at the 3 years so far of the COVID-19 pandemic. Looking at cases, which peak out at about 1,300 per day. The number of hospitalizations peaking out a little over 300. And then looking at our deaths, and we've had as high as 75 on average on a day. But keep that in mind as we start looking at some of the other aspects here. So if we look at the hospitalization rate, early on, those initial cases, we're seeing upwards to 60%. and that has now dropped down considerably. The overall hospitalization rate has been about 3.7%. The overall case fatality rate, about 0.8%. But as you can see early on, upwards of 5% of cases were dying. But what we've seen over time is this continual decline with a few ups and downs from it. And if we take a look at what's going on, in the pre-Delta era, case fatality was about 1.5%. In Delta, dropped down about 0.8. And now with Omicron, we're about at 0.5 or 0.5%. So 1 out of every 200 people. And just so you keep that in mind, it turns out that influenza is about 1 in 1,000. So right now we're still having a case fatality about 5 times greater than influenza. Thinking in terms of the pre-vaccine era for COVID-19, our death rate was about 1.8%, dropping down with the first rapid uptake of vaccines to about 1.2. And then now, since we've had vaccine coverage stability, i.e., most everyone who's gotten or who's going to get vaccinated has already been vaccinated at this point in time, we're running at about 0.7% case fatality. So overall, we're now at 34 months with multiple waves of a highly transmittable virus, extensive numbers of cases and hospitalizations, high numbers of deaths, but a shifting case fatality rate, which we see with the combined effects of variants, vaccines, and public health measures. So let me talk a little bit about our variants out there. SARS-CoV-2 is a virus that likes to change. It has a fairly good potential for mutation. And this is the phylogenetic tree, basically, of SARS-CoV-2. And what we see are things that just kind of take off and end up in a situation where they replicate and really take off. So over time, we've seen transmissibility, or that notorious R0, increase. So Omicron is quite a bit higher than Delta, higher than Beta, higher than Alpha, which is higher than the original strain. At the same time, we've seen a continuing decline in the estimated incubation period. And I just point this out, this is the genomic surveillance going on across the United States and done by CDC. We've had an unprecedented number of viruses that have been sequenced. We're looking now at millions of viruses that have been sequenced so far. And we get granularity in terms of the genomics more than we ever had with any other infectious disease. But I want to just point out here, right up here is something that you may not have heard of, BF7. And BF7 is increasing not only here, but across the world. It used to be known as BA2.75.2, which is a subvariant of B5 viruses, but has now earned its own category. 2 studies out there in preprint conclude that this virus escapes antibodies from vaccine or previous infection better than many of the other Omicron. And an evaluation of Evusheld has shown that this is the most neutralization resistant variant evaluated to date. So we just have to kind of keep our eyes open on not only BF7, but all the other hundreds of thousands of variants that are emerging all the time whenever you have a virus that is in so many people. That's my reminder that sometimes I hear people talking about how evolution, can lead toward greater transmissibility, maybe greater immune escape. But at the same time, people are under the influence that virulence, or the amount of pathogenicity, is likewise going to diminish over time. And these three things are relatively independent of each other. So we could end up with a highly transmittable immune escaping virus that is much more highly virulent than we see right now. So we just have to be very, very cautious and keep our eyes open as time goes on. Now, we now have 4 authorized and some licensed vaccines in the United States: the Pfizer, BioNTech, Moderna, the Novavax, and the Johnson Johnson Janssen vaccines. And I just point out, we now have vaccine that has been authorized all the way down to 6 months of age. And depending on your age and the vaccine, there are different rules out there in terms of who can be boosted. So right now, if you're 12 and older, basically anybody can be receiving the bivalent booster. And depending on the vaccine, it can be either the Moderna or the Pfizer for the booster. The ACIP is shortly going to move away from thinking in terms of how many boosters you've had, rather moving into, have you had the primary series and have you had a recent booster? So I think we're in the evolution toward an annual booster for this virus. Across Wisconsin, we still see about 35% of our population totally avoiding vaccine. About 36% completed their primary and have received at least 1 booster, if not 2 or 3. And then we have our 30% of the population that have received at least 1 vaccine dose, but don't typically go much more past that. What we've seen as a consequence is an evolution in who has the bad outcomes from COVID. This is data from Tennessee, but showing the emergence of a significant disparity between rural and urban populations in terms of death rates, starting in about July of 2000 and continuing until present. And this is largely driven by a rural-urban divide in terms of acceptability of COVID vaccines. If we look at Wisconsin, our 2 least vaccinated counties, one at 74%, the other at 72%, compared to Dane County, which is the most vaccinated at 14% under vaccinated, we see a 5-fold difference occurring. In terms of the currently authorized treatments, we have basically 3 antivirals and 1 monoclonal antibody. Paxlovid is twice daily for 5 days. Anybody over 12 years of age. Molnupiravir is also twice daily, 5 days, but licensed only for adults. Remdesivir typically is reserved more for hospitalized patients. It's an infusion for 3 consecutive days, but basically these are people within the hospital. And bebtelovimab is a monoclonal antibody, and this is a single IV injection that can be started within 7 days of onset. This is used extensively in the state of Florida early on, or about a year ago. Now, a quick update, if people are interested in this, the bebtelovimab is no longer provided free of charge by the federal government. And the approximate charge for this infusion, this one-time infusion, is close to $6,000. And it really depends on the insurer and the patient whether or not this would be covered or not. Moving on, this is just something we came across in Dayton, Oregon, about a year and a half ago. And I thought it appropriate to talk a little bit about public health measures and, again, a rural-urban divide. this has been studied, and rural residents are significantly less likely to have worn a mask in public, sanitized at home or workplace, avoided dining in restaurants or bars, or working from home. And this is found even if you account for political ideology, demographic factors, and COVID-19 experiences. But again, we see an exacerbation right now, more between rural and urban counties than really any other demographic out there. Accordingly, health messaging is really, really important to try and get COVID-19 prevention into rural areas. Now, this is data from my own team, and thanks to Maureen Goss and Cecilia He for this. This is looking at what happened in the Oregon School District, and just pay attention to that squiggly line there. That is the percent of households that have a new acute respiratory infection. We have about 200 households recruited that report weekly. And this was a project funded by the Department of Family Medicine and Community Health on a small grant. And the idea was to do this for a year, and we've been doing this now continuously since November of 2019. But as you can see, that at baseline, roughly about 40% of households had respiratory infections. Once the schools shut down in March of 2020, this dropped down precipitously to about 8%. When schools came back with phased reopening, physical distancing, hybrid education, and masking, the respiratory infections stayed quite low. Once they relaxed and required only face masks, things jumped up considerably. And especially as we saw a new variant, the Omicron, come through, it jumped up more. And now when we came back last year, basically in March, to face masks being optional, we resumed almost the baseline or the background level of acute respiratory infections. And currently in this school year, we're back to where we were prior to the pandemic in terms of households with respiratory infections. So I think this illustrates the effects of these public health measures quite nicely. The other thing just to mention very quickly is we're now moved into kind of keeping track of what's going on by county and making decisions based on that. So as we're in a low transmission mode, basically instructions are keeping up to date with vaccines, getting tested if symptomatic, and across all these, staying at home when you're sick. And if you require isolation and quarantine, go ahead and do so. So 6 factors to watch in my mind with COVID and SARS are the variants, the vaccines, our vigilance, our willingness to test, use non-pharmaceutical measures when things become more or a higher transmissibility or a higher level of infection, and the whole idea of ongoing surveillance. Unfortunately, as testing has dropped off, our surveillance efforts have dropped as well. On top of that, we have to look at resilience, especially in rural areas, responses to economic factors, the long COVID, despair, alcohol, anxiety, depression, drugs, suicide, adaptation, and communication are all going to be important going forward. I just want to show this. This is from the Scenario Modeling Hub. And these are all a number of sites that have been doing very high-level modeling of COVID. And just as an inkling of what might be coming ahead, I think all the models predict some increase in cases, hospitalizations, and deaths as we go through this fall toward January. So we'll just have to keep our eyes open and try and keep safe out there. So the long tail of COVID-19, we have had really some significant enhancements of health disparity in terms of economic issues, in terms of who gets sick, reductions in access to care. The things that are somewhat undefined right now are the long COVID, the effects of bereavement, the anxiety, depression, personality change. I'll touch on that on the next slide. Substance abuse and substance use abuse, delayed or missed care, our need to bolster public health. We have a lot of catch up in other areas, ongoing need for surveillance. And again, just that communication is so incredibly important. As far as personality, the question is, are we all becoming jerks? Throughout the pandemic, through a really, really good study that was just published about a week ago, we have seen significant declines in extroversion, openness, agreeableness, and conscientiousness. And the levels to which they're changing over the course of a year are equivalent to what we normally see over a decade in an individual. But unfortunately, we're seeing this all going into a less agreeable society, which is something we desperately do not need at this point in time. This comes from UW Health and courtesy of Mariah Quinn, our Chief Wellness Officer. And this is off a quick survey done 2-3 months ago, describing one way in which the past 2 years have impacted you personally. And again, these are healthcare workers and obviously work, but friends, family, lost, and so on. Another question asked, what connections have sustained you over the past 2 years? Have you found new connections at work or family or community? And again, what sustained people is family, friends, and connectivity. So if you have a chance right now and can direct your phone to this, this is the next set of UW Health wellness questions that Mariah asked me to insert in this talk. So happy to do so. We'll give you just a couple more seconds here. All right. So take-home points for SARS-CoV-2. It's not over. There's such a delicate interplay of virus evolution and human behavior. This is a virus that can change a lot and continues to surprise us, so we'll have to wait and see. But we do have some means and measures for control. The vaccines we have are safe and effective. They may not prevent infection, but they do moderate the outcome of illness. We have antivirals and monoclonal antibody. There are public health measures, and coupled with personal responsibility. I'm not sure if people saw the study that just came out in JAMA a couple days ago, looking at the level of people lying about what they did during the pandemic in terms of not staying away from work, not testing, showing up at parties, at get-togethers while symptomatic. So personal responsibility is really important here. There are really significant and yet to be defined long-term impacts of COVID. And finally, the importance of family, friends, and connections. So we're going to shift to monkeypox here. And this is from Mary just a couple days ago in terms of an email. And she is one of the clinicians who have seen one of the 10 cases of monkeypox within UW Health. Patient turned out to have monkeypox, was not extremely ill, and had had a first vaccine dose about a week before presenting with symptoms. Patient was not treated with antiviral, and from what I hear, is doing well. We have had 83 cases in Wisconsin. So by way of just review, monkeypox is a double-stranded DNA virus. It's one of 3 human orthopox viruses that include variola, the cause of smallpox, cowpox, and vaccinia, which we use for the smallpox vaccine. Generally, this is a zoonotic disease, animal to human transmission. And there are 2 clades located in the Congo Basin and West Africa. Brief history, which really centers on Wisconsin. The very first cases, or the first description of monkeypox and how it got its name, was in outbreaks of vesicular lesions in 2 colonies of research monkeys in 1958. And that's where the name monkeypox comes from. But in 2003, so 19 years ago, there was the first outbreak and first reports of monkeypox outside of Africa. And the epicenter was actually Wisconsin. And this was a zoonotic outbreak. That transmission occurred from small mammals from Ghana that transmitted to pet prairie dogs in pet facilities. And these animals were adopted and transmitted monkeypox to humans. I think we had all of 47 cases at that time. The clinical course from exposure onward, incubation is about 8 days, but can be as long as 21 days. People tend to have a prodrome lasting anywhere from 0 to 5 days, but typically about 1 to 2 days. The transmission is by bodily fluid. Close contact can be from large respiratory droplets and fomites or contaminated material. There is some emergent evidence for sexual transmission, i.e. DNA and seminal fluid. After incubation, during that prodrome, we tend to see the nondescript or the pretty nonspecific symptoms of fever, headache, lymphadenopathy, back pain, myalgia, asthenia. And then shortly thereafter, we see the emergence and progression of the rash from macules to papules to vesicles to pustules to crust. And Mary indicates that with her patient, there was all of 2 skin lesions. Skin lesions traditionally look like this, described as rubbery or firm-based. Will morph into the vesicular lesions, eventually will crust and come off, and people are contagious until that crust comes off and there's replacement with normal skin. This is the most recent data from CDC looking at symptomology, and I just want to point out that the big ones are rash, itching, lymphadenopathy, and rectal symptoms. These are the ones that kind of jump out to me as being different from the very nonspecific. So kind of keep these in mind as you're seeing patients out there. But again, 97% with a rash. So that should be the first clue there. As of today, about 71,000 cases across the world, 26 deaths. In the US, we proudly claim 37.5% of all global cases. Other places in the world started out with many more cases, but brought things under control faster than the US. As far as the US, we've had about 2,700 or 27,000 cases so far. And just by way of comparison, by March 22nd of 2020, our cumulative COVID case count exceeded 31,000. So these are very, very, very different viruses in terms of the rapidity of spread. One thing I want to point out is over time, we've seen a decrease in white patients and a predominance of Black and Latinx patients with monkeypox. If we take a look at age and gender, about 95% of cases have been male, almost 60% within the demographic from age 26 through age 40, and 75% have reported male-to-male sexual contact, but in some series, we see that number as high as 96, 97%. And very, very few cases have been pediatric. In response to this epidemic, there have been significant changes in behavior. This is from an online survey done by CDC. This is from August, and about a 50% reduction in number of sex partners, a reduced amount of one-time sexual encounters, and a 50% reduction in partners met on dating apps or sex venues. So there has been this profound behavioral response to this outbreak, which really has resulted in the change in the epidemic, as shown here. So the top panel are cases demonstrating at least some error around it. But you see almost a classic epidemic curve with an increase on up. Early on, for the first 7 or 8 weeks I was following this, we were following an exponential increase with a doubling time of about 7.5 days. And then all of a sudden, things slow down. If you take a look at the lower graph, that's the transmissibility, or the R naught. And in about August, that R naught crossed the unity line at 1. And that means that all of a sudden, you're no longer increasing number of cases per generation, but you're actually seeing decline. And going out into beyond the data used for this modeling, we see that the forecast is for continued decline out there. So keep the fingers crossed. In terms of vaccines for monkeypox, and as Mary had indicated with her patient who had a first dose a week or so before coming in to the clinic, there are 2 vaccines that are FDA licensed and available. ACAM 2000 is actually licensed for prevention of smallpox, but has been shown to be effective for monkeypox. Jynneos has been licensed for prevention of smallpox and monkeypox, and is basically the vaccine that has been used. A couple things to keep in mind. ACAM 2000 is a live viral vaccine, and this can be very, very harmful for somebody who's immunocompromised, somebody with significant skin conditions like eczema, and best to avoid in those situations. Jynneos, on the other hand, is a live but replication deficient virus. And because it's replication deficient, you actually need 2 doses to get fully immune. But it's well tolerated. It doesn't have those risk profiles. And early on in this outbreak, studies were done to show that by injecting in the intradermal space, we could get a dose sparing. So 1 dose could be extended to 5 doses in that method of deployment. There's pretty good information data out there that shows that if the vaccines are provided within 4 days of exposure, they can actually prevent monkeypox. So far in the United States, we've had about 875,000 doses administered, and the estimated vaccine effectiveness right now is 93%, or a 14-fold reduction in monkeypox. And in the graphic, you can see the dark bars showing the increased use of monkeypox, through about early August, and then an increased use of that 2nd dose. As far as treatments, there is just one authorized by FDA called tecovirimat, or TPOXX. And this is an investigational new drug protocol that has to be orchestrated and worked through with public health and CDC. There have been about a little over 4,000 treatment courses provided so far. And this medication is indicated for people who are more likely to get severely ill, so people who may be immunocompromised. So take-home points with monkeypox. Number 1, it's declining. And it's been declining because of vaccination, behavioral changes, and awareness. There has been phenomenal information going out across the existing HIV AIDS networks, and the result has been very, very profound. We do have some means for control in terms of the safe and effective vaccines, antiviral use, and the public health measures here. So I'm going to just diverge from what I said I was going to talk about and just give a quick update for everybody on acute flaccid myelitis. If you're not aware, this is something we've seen occurring since about 2014, occurring every 2 years. Tends to occur in the even years. We don't quite know why. But acute flaccid myelitis is something that we see predominantly in young children, resulting in severe respiratory and neurological complications. And the main thing is a sudden onset of paralysis. This is, we think, mostly caused by enterovirus D68. And just make a mention that you're aware of this and that any suspicion should be result in coordinated sampling and a discussion with public health. Okay, I'm going to move on to flu very, very quickly and then hopefully have some time for questions. So influenza, very, very quickly, is increasing. The graphic here shows the number of positive tests reported to CDC by our clinical laboratories, and this goes back over the past 1 year period. Number two, what we're seeing out there from public health laboratories is predominantly influenza A, H3N2. And if you recall, this is the one that is probably more harmful, especially to older individuals. Across the country, we're seeing more influenza-like illness in primary care venues. So the graphic here shows the weeks of the year going back a year, and the percent of visits in primary care for influenza-like illness. And the red triangles represent 2021, 2022. So it takes us up to present. And we're at the highest level of influenza-like illness in this country that we've been at since the 2009 pandemic, which was an incredibly early year on the basis of being a novel strain. Also across the country, we're seeing increasing respiratory illnesses in children, shown in orange, and young adults in gray. And older individuals, we're not seeing so much of that, but closer to home, at our urgent care centers, we're seeing the same pattern. Last week, we saw a big jump up in influenza-like illness cases at our 2 urgent care centers, and most of that increase has been in kiddos. The other thing just to point out very quickly is we have been in a stage of increased deaths in the United States for pneumonia, influenza, and COVID-19 ever since December of 2019. We have not dropped below the baseline or the epidemic threshold across all that time. And so the graphic here shows the percent of all deaths in the United States that are due to pneumonia, influenza, and COVID-19. And the saga unfortunately continues. So my influenza take-home points here. Number one, we have very little natural immunity to influenza at this time. As soon as schools shut down in March of 2020, influenza packed its bag and left. We've seen very, very little influenza over the last 2.5 years. We've seen unfortunately, declining rates of influenza vaccine utilization. Currently across the United States, less than half of individuals indicate they're planning to get vaccinated this year. By way of disclosure, I got mine at clinic 2 days ago. We recommend the enhanced influenza vaccines for anybody aged 65 and older. And so this is particularly important this year. And when we say enhanced vaccines, these are the high dose influenza, including the recombinant influenza vaccine. The recombinant has a higher antigen content than do the standard vaccines. Or this means an adjuvanted vaccine, one that contains the chemical that enhances the immune response. In terms of antiviral medications, no big changes there. Oseltamivir is indicated for anybody over the age of 14 days. It's a twice daily, 5-day course. Zanamivir is an inhaled powder approved for individuals over 7 years. This again is twice daily for 5 days. Balaxavir, indicated over 6 months of age. It's a, and I have an error here. It's an oral dose. Balaxavir is oral, and it's a one-time dose. So I will change that. My apologies. And Peramivir, indicated for age 6 months and older. It's an IV single dose, typically used only in a hospital setting. So my overall take-home points here, SARS, COVID-2, monkeypox, influenza are communicable. They're able to be transmitted from one sufferer to another. On the scale of things, SARS is incredibly transmissible and is only eclipsed by measles. Influenza is quite a bit less transmissible than SARS, but still respiratory droplets in close contact. And monkeypox is not very transmissible and requires that close skin-to-skin contact. There are safe and effective vaccines that are not only available, but vastly underutilized. They can prevent infection, but more importantly, they modify illness and the consequences of illness. Antiviral medications are available for all 3 of these viruses and continue to be underutilized. And the public health measures actually do work, should we decide to use them. So I'll finish up there. Thanks for your attention.